Good evening, everyone. Back here in India. Good afternoon to all from UK. Today we have an important presentation by Professor Dominic Wilkinson from University of Oxford. I have worked under Professor Dominic Wilkinson for about a year, and I'm a big fan of him, both as an academic as well as a clinician. He is the director of medical ethics and professor of medical ethics at University of Oxford. He is also a consultant neonatologist at John Radcliffe Hospital in Oxfordshire. He is presently a senior research fellow at Jesus College, Oxford. He has published more than 180 academic articles related to ethical issues, not only in newborns, but as well as in children, in adults as well. He has authored many books, of which I would highly recommend The Carmentis Machine, which was designated as the best book of the decade in bioethics. Apart from all these, he's a very good clinician. Difficult cannulas, we used to go to Dominic only for his help. I still remember those times when we had this load of babies coming into the newborns at the same time. And he used to give us a helping hand, despite being so senior. So welcome, Professor Dominic Wilkinson. We are eagerly awaiting your talk. We also have with us two eminent people who will chair the session. I would like to introduce Dr. Naomi Leventhal from University of Michigan. She's a good friend of Associate Professor Gary Weiner, who was our previous speaker in this webinar series. She is presently the chair of American Academy of Pediatrics Bioethics, and she serves as consultant neonatologist at CS Moore Children's Hospital, and she's the director of neonatal prenatal consultation clinic there. And her interest includes neonatal bioethics, and the main thing is she is the chair of bioethics, and we have to see what she has to say on this contentious topic. We also have with us Professor Suman Rao. She's a senior neonatologist from India. Professor Suman Rao serves as the professor of neonatology at St. John's Medical College, which is a tertiary care center in Bangalore, and a teaching institute as well. She also served as the WHO medical officer in the Department of Maternal, Newborn, Child, Adolescent Health and Reproductive Health at WHO in Geneva 2018. She is also the national consultant for kangaroo mother care. Her recent paper that was published in New England Journal of Medicine was a breakthrough one, which had shown the importance of KMC in low resource settings such as that of ours. She is also presently the chairperson of Perinatal Committee of National Neonatal Forum in India, and she was the secretary of the National Neonatal Forum Karnataka chapter for the years 2007 to 2009. I welcome all three of you, and I welcome all the delegates as well. Firstly, I would like to ask Dr. Naomi as to what she has to tell about today's topic. Over to you, Dr. Naomi.
Good morning. Can everyone see my slides okay?
Yes.
Okay, great. It's really a pleasure to be here. Thank you so much for the invitation and for allowing me to share the stage with these folks. I do want to point out that all three of us are neonatologists, which I think is sort of interesting given that we're not here to talk about a specifically neonatal topic, but I think that does speak to the sort of deeply enmeshed relationship of bioethicists and neonatology, and so it's not entirely surprising that that's the case. But I'm really happy to be here, and I am going to keep my comments brief because I don't know exactly what Dr. Wilkinson is going to say, but also I really want to give him time to say it. I do want to point out that although, sorry, I'm not advancing. Although I do have this new role being deeply involved in bioethics for the American Academy of Pediatrics, what I'm saying today, this is my own views and my own kind of ethical postulations, and this doesn't represent policy or position of the AAP. So, you know, I've given a lot of talks on COVID in the last year and a half, and it's really interesting to go back and look at previous slide decks and think about what I said before and where we've gone over time in thinking about this pandemic. And one of the things that's clear to me all the time when I think about bioethics and COVID for children is that there are some ways in which it's brought up things that we have talked about again and again and again in pediatric bioethics and in bioethics more broadly, but it's also introduced new things that we either hadn't thought about before or had never really had to think about specifically before. And there were some theoretical challenges that finally played out in front of us. Particularly if you work in a resource-rich setting like me, I hadn't really had to grapple with scarce resource allocation before this pandemic in the way that I have in the last year and a half. And all of this has changed as our understanding of the disease has changed. You know, before we started talking, we were talking about the Delta variant. And one thing that's really interesting to me is when I go back and look at my previous slide decks, first we weren't talking about vaccine at all. And then I was talking about vaccine research. And now we're talking about a fairly well-vetted vaccine and who's going to get it. And so we're constantly having to pivot and reframe and rethink about the things that we're doing. But at the heart of all of it, we keep coming back limited biomedical and public health resources. And that just again and again is what we talk about when the whole world is affected and we don't have enough of things to support everyone who needs help. But so to pivot to vaccines a little bit, I think there have been a lot of different ways that we've talked about vaccine ethics during this pandemic. One, I think, has to do with just emerging treatments and whether or not we are sure that emerging treatments are safe, particularly when we're rolling them out on this mass scale like we have seen. And early on, we talked about wait, slow down, make sure everyone has gotten the data that they need and that we've done this right to be sure that the vaccine is safe. Then we really pivoted towards making sure we included children in vaccines. But at least in a practice setting like mine, where we think a lot about vaccine hesitancy and where we worry a lot about just in general acceptance, public acceptance of vaccines, we saw a lot of potential vulnerability for vaccine uptake more broadly and thinking, if we get this wrong, if this hurts people, if it doesn't work, will we not only undermine confidence in this vaccine, but in other vaccines in a way that's already a problem for many practice settings. On the other hand, we talked about children and their unique vulnerabilities, and there was this sense of being left behind for both healthy children and children with particular medical and psychosocial vulnerabilities, and thinking, can they really wait? Is it really right to put this off? Is the age de-escalation strategy that the vaccine manufacturers have taken on what we want? And among people that I know, children of physicians, there was a lot of clamoring to get into these trials. I'll tell you, my own children are still on the wait list for the Moderna trial in the Southeast Michigan area. But I think as we think about this and the vaccine in particular, I think one question this poses is, what do we as a society owe to our children? And where do they fall when we're thinking about distributing resources? And I think we've had to ask that again and again. But the other interesting thing to me about vaccines in kids is that vaccinating children isn't just about keeping children safe, right? And we thought about the impact of vaccinating kids, particularly older kids, on stopping the spread of the vaccine more broadly. And asking ourselves questions, when we vaccinate our children, is it to keep them from getting COVID, or is it to keep their grandparents from getting COVID, to keep their teachers from getting COVID? And so in my life as a bioethicist, I haven't thought a lot about what do children owe society and what do children owe us. But in some sense, we've thought about kids have obligations to the rest of us. And I think when we're thinking about an investigational vaccine for children who don't seem to get very sick, I think this question of, are we asking children to pitch into an effort, is an interesting one that we don't talk about very often. And I think that the other way that the role of children in society has been just challenged again and again and again has to do with other potential benefits of getting kids vaccinated. And that, to me, nothing is more salient than the issue of getting kids into schools. And if you're like me in Southeast Michigan, my children were home and doing virtual school for the better part of a year. And I know that this has affected children in India and around the world as well. And that sort of relationship of vaccination and kids, and are there reasons other than direct benefit of the vaccine to get kids vaccinated so that they can go to school? We know in the United States that the most disadvantaged kids are the ones who are affected the most adversely by being home from school. And I just want to point out, I talk a lot about the effect of the pandemic on vulnerable children, but all children are vulnerable. That's inherent in who they are. Even healthy children are vulnerable. And so I think in trying to parse out healthy kids versus kids with disabilities or kids with chronic illness, we have to remember that developing brains are inherently vulnerable. So I'll wrap up by just making a couple of points and then allowing these other folks to share their thoughts with you. But one is what I've said, which is over and over, the COVID pandemic has required us to closely examine the moral and political standing of children in society, both in terms of what we owe to them and whether they owe anything to us. I think thinking about whether or not children are prioritized or actually demoted in a vaccine allocation scheme should be about more than just this risk-benefit calculus about who gets the most benefit from being vaccinated. I think that benefit comes in a number of ways. Anytime we talk about prioritizing adults over healthy children as part of a global vaccination allocation schema, I think we have to think about whether in a collective global way, we are really ready to make that a zero-sum game, and whether it's actually true that prioritizing one group over the other in a global context distributes the resources the way we intended. I'm not convinced that as a global society, we are able to coordinate that well, but I think that that's something to think about. And then finally, I'll hedge that by saying that I think concern about fueling vaccine hesitancy really is rational and is something that we have to think about. And if the cost of pushing vaccine to children is reluctance, a chilling effect on vaccine uptake more broadly, that threatens child health in a whole different way, and we have to be aware of that as well. So with that, I'm going to stop sharing and listen to these other folks. And I think if there's time, I'll be back a little bit at the end to participate in some discussion.
Thanks, Dr. Naomi, for your wonderful insights. We'll get back to you with audience questions after the talk. I would like to know what Professor Sumanro has to tell about this topic for today. Madam?
Yeah, thank you, Dr. Veer. And I'm really excited to listen to Professor Wilkinson and Dr. Naomi. Your thoughts were really thought-provoking. And I'm sure Dr. Wilkinson will have the answers to all your questions. My concern with the big pandemic as far as children is concerned is all the huge indirect effects that they are facing. Not only in, even though they don't have much of direct effects because of, they are sort of maybe more protected, less vulnerable than the aged, but the indirect effects which will have long-term implications are huge. And therefore, how as a society we can mitigate these effects is the big question that I have. And as far as vaccines are concerned, children are the last group that we are vaccinating. Yes, on one hand, we are all eager to do so, but we also know that these vaccines are not really time tested. So what is going to be the effect in the long run? Are we really ready to do it on children who are not bearing the brunt of the disease process? That's the big question that I have in my mind. And with this, I would hand over to Dr. V to invite Dr. Wilkinson to deliver his lecture.
Thank you, ma'am, for the opening remarks. Professor Dominic, you can take over from here.
Thank you. I'm gonna do my bit of screen sharing if I can make it all work. This is always the nerve-wracking moment where we get to see if the technology is going to behave. So I'm hoping you can see that. Good. I can see it, so I'm hoping you can see it. So brilliant introduction there from Naomi and Dr. Rao. And I'm going to skim over some of the things that they've highlighted already. So what I said that I would talk about in this talk is about children and vaccines, but I'm going to start by going over some of the issues that Naomi's highlighted, which are some of the general issues about ethical issues in the pandemic. So one of the fundamental challenges that a pandemic causes is simultaneous illness and demand. And because of the very large numbers of people involved, the millions of people who are simultaneously ill or at risk of illness, we've seen this problem of demand outstripping supply. And at the same time, we're in a setting where there's significant uncertainty. That's because this is a novel threat. So we don't have the luxury of experience of this particular illness or of the particular therapies. So these are the two kind of simultaneous challenges. We've got a big demand, more than we can deal with, and we're in a situation of scientific and moral uncertainty, and that plays into the ethical problems that we face. And one of the central ones is that we have a sort of tug of war, which occurs at different points and different levels between individuals, between groups, all wanting the same things, wanting to be safe from the virus, wanting to recover from the virus, wanting to return to normal life. Now, these issues of resource allocation, we started, many of us started thinking about at the beginning of last year in the context of the kind of pressing ethical issues that we were facing around respiratory support and ventilators. And the issue that in the UK we were faced with at the beginning of March last year were projections of the amount of demand for intensive care that vastly outstripped. Down here is the intensive care capacity. These curves here for the projected first wave and second wave were vastly in excess of the number of ventilator beds in the UK. And the UK has a relatively small number of critical care beds per capita for a developed country, though it is much better off than many lower resource settings. And as pediatricians, what we were thinking about at the time, our adult colleagues, and I was doing a lot of work on thinking about how adult colleagues might make decisions for adults, but how would children factor into this particular problem? Well, they might factor in because we might have to choose between children. So this is what I call direct competition. Or there was a possibility that we might have to make choices that posed between adults and children. So if there were enough adults critically ill, what if they encroached on our pediatric critical care spaces? Who should get the critical care space, the adult or the child who is seriously ill? So we were having to think about these difficult questions. And there were guidelines in the UK as elsewhere about what ethical principles we might resort to for this sort of acute resource allocation question. And the basic principle that most guidance lent on was that we should give priority to those who had the highest capacity to benefit, who were most likely to survive if they needed this therapy. There wasn't there was talk about using the same intrinsic principles for children and adults, thinking about who might be able to benefit quickly. Although the UK does have limited intensive care resources, we certainly don't normally have to think about the possibility of children and adults competing for critical care capacity. So these were challenging things for us as clinicians and ethicists to think about. However, in the first and second waves in the UK context, this acute direct competition problem didn't seem to eventuate, and many have expressed either explicitly or implicitly that we just didn't see this problem in reality, and that was partly because our pediatric intensive care capacity was able to be reorganized. So there were pediatric intensive cares that closed and reallocated their beds to critically ill adults, but actually other PICUs expanded. And at the same time, in the UK, in the first and second waves, we saw actually very dramatic reductions in pediatric presentation. So not only did children not become ill from COVID, thankfully, so that was a huge relief, but actually there were very significant reductions in the normal numbers of admissions. And that was because there were the social distancing measures and other measures that we took as a society actually had very dramatic beneficial effects for children, in terms of a number of illnesses. So particularly respiratory illnesses. So this red dot here is 2020 compared to other years, the number of admissions per 100,000 children. The number of ventilated admissions in 2020 were remarkably and very significantly. They were about halved compared with normal. So that enormously relieved the pressure for this acute direct competition problem. Of course, we thought, we can breathe a sigh of relief. We don't have to have this awful situation of adults and children competing, who might get the ventilator. In our relatively fortunate resource-rich setting, at least, we avoided that problem. Of course, not all resource problems were solved. There remain uncertainties about just how much rationing might have occurred within the adult ICUs and on what basis. But as Dr. Rao highlighted, direct effects on children from the pandemic were the smallest of the effects. There was another problem that we found, and this was indirect competition, because what we had were very dramatic changes to life, to way of life, for the sake of adults at the cost of children. So adults being vulnerable from COVID, we had all these radical changes to a lifestyle, all these effects on education that then adversely affected children who were not at risk from COVID. And we saw consequences of these changes, not just in education, that was very significant, and Naomi's pointed to that already, but also in other medical, in terms of other medical problems. So I'm not sure what the situation was in India, but we saw a number of really concerning reports of increases in non-accidental injury related to children being in home environments rather than being in potentially in protected school supervised education environments, with parents being enormously potentially stressed, unemployed, potentially mentally ill, as well as missing out on some of the normal oversight and protective influence, both of teachers, social workers, etc. So there was a very significant increase in non-accidental injury reports, including very severe, some of the most severe head trauma. We saw striking increases in reports of mental illness, particularly in children. In fact, reported more in children, particularly in relation to severe eating disorders, than in adults. And we saw a very dramatic effect on healthcare access for other types of illness. So although respiratory illnesses and some other illnesses were reduced, some trauma, for example, accidental injury as a result of sport and as a result of traffic accidents, for example, were reduced because people were traveling or involved in sport, etc., were reduced. But other sorts of normal healthcare needs were switched to telemedicine, surgery was cancelled, appointments were delayed or were occurring virtually. So there were very significant indirect effects on children. So it wasn't the case that there was no problem. It did look like, although it wasn't direct competition, that children and adults were competing or in a problem of scarce resources. Here, this is a problem of the resources of our health system and also the consequences of our response to the virus, and children were potentially losing out. So this raises an interesting and not much reflected on problem about how we prioritize if we have if we have scarce resources, or if we're having to make choices where children and adults are competing. Who gets the limited resources? Whose well-being should we prioritize in this sort of scenario? Well, it seems like that there might be 5 different answers to this. So one answer is an attractive answer sometimes to doctors. It's one that doctors sometimes resort to when resources are scarce, which is to say, well, whoever gets here first gets the resource. That's how we normally make decisions about who gets the theatre tickets, or who gets the new product in the store. We have a queue, and those who are at the front of the queue get it, and those who are later arriving don't. It's easy to administer, but first come, first served as an ethical approach to scarce resources is problematic. And it's problematic because not everybody who's in the queue might benefit equally from the scarce resource. So you might have people who are at the front of the queue who actually aren't very sick. And some people might be able to get to the front of the queue easier. And that's a particular concern because of the types of inequalities that the pandemic has also highlighted. That there are people in our society, particularly who are more disadvantaged, who might present to hospital later, who might present for medical care later. And if you have a first come, first serve system for allocating oxygen, ventilators, intensive care, then they might be very significantly disadvantaged. So first come, first served is a convenient but not attractive ethical approach. We could, and it's attractive to pediatricians, say, well, look, if adults and children compete, we should always give children priority. And of course, if we take that approach to thinking about the pandemic, then it should mean that actually we shouldn't sacrifice children's well-being at all for the sake of adults. But that too doesn't seem like a very attractive ethical approach, because what's been at stake in the context of the pandemic have been lives of many millions of adults. What's at stake for children is very significant, but it doesn't seem right to say, well, look, children should always have priority. If we think about, Naomi raised the question about children's obligations to the rest of society. And I think that there are important questions about how strenuous or how stringent those obligations might be. But to say that children have no obligations to contribute to in a situation of scarcity seems like the wrong answer. We could take the opposite answer and always give adults priority, but I think as pediatricians, we're going to reject that immediately. Just because children don't vote or they're less vocal, we shouldn't simply give the adults priority. We could take the utilitarian answer, so we could focus on, well, look, who of the adults or the children are going to benefit the most. We could look at the overall effect on well-being of the sacrifices that children have made, and look at the overall impact on well-being and quality adjusted life years of adults, and try and come to some utilitarian answer. It'd be very difficult to know if overall we're causing more harm than good when we're thinking about lockdowns, for example. So there are real problems with working out what would secure the greatest well-being for the greatest number. But that approach, which some of the guidelines have endorsed, would in many situations give priority to children because in most circumstances, they're more likely to survive 4 more years. So you're going to secure a greater benefit by giving priority to children. Or, and this was something that Naomi was gesturing towards, we might think about giving relative priority to children, not because we'll get more life years or because they have a higher chance of survival, but because children are important in some other way. And I'm going to set out some of the arguments in favour of giving relative priority to children as one part of an ethical response to scarcity. And these are some of the arguments that are set out in this excellent paper by Brian Antiel and John Lantos and Govind Persad in Pediatrics from last year. If you're interested, I'd recommend it. So one reason for thinking that this might be an ethical answer is because of an ethical principle of priority to the worst off. So when we're thinking about ethical approaches to resource allocation in scarcity, one answer, and it comes from some of the philosophy and ethics that comes from an approach called contractarianism, the American philosopher John Rawls, is the idea that if we didn't know, if we were trying to devise a scheme without knowing whether we were going to be rich or poor, healthy or sick, if we were trying to think about it, what resource allocation scheme would we choose? We would devise a system that gave some significant priority to those who are going to be worst off, because we would want to reduce our chances of being in the worse off position. So that gives rise to an ethical approach sometimes called prioritarianism. And it's not an absolute priority to those who are worst off. In medicine, we often talk about the idea of prioritizing those with greatest medical need. When we're thinking about those whose well-being might be sacrificed in a pandemic, or who might get seriously ill, the young are in one way worse off because they haven't already had a chance to live. They haven't had a chance to go through the normal stages of life. And if they suffer at an early stage, that will have very significant impact for them for a long period of time. Although if we gave priority to the young over those who are older, that would seem to be favouring one group of society over another. In another way, such a principle would be both egalitarian and non-discriminatory, in the sense that we all, of course, have been or are young. I'm no longer, I think, in that category, but some of you may be. And of course, our children are still, and their children will one day be. So an approach that prioritizes the young is, in a sense, responding equally to a phase that all of us experience. In terms of one of the challenges of the pandemic, that it increases social inequalities, priority for the young potentially reduces social disparities because those who are most disadvantaged tend to be younger and to have more children. And there's some evidence that if you ask the public about priorities, that some of the research that I've done during the pandemic has done just that, that they in general support the idea that if you have to make difficult choices, you should prioritize those who haven't yet had a chance to live through life. You should prioritize children. And many of us have strong intuitions. I mean, we're pediatricians, so we would, but that it's important to give priority to the young. And in the paper in Pediatrics, they also make the claim that such an allocation scheme would also be lawful, though of course that's going to depend on the law that applies in whatever part of the world you are in. So if we take an approach of giving relative priority to the young, that might have implications for some of these direct competition cases. If we run out of ventilators or oxygen, which we didn't do so far in the UK, but there were some resources that we did become critically scarce that hasn't been widely discussed. So ECMO, which is an extremely scarce resource. The ECMO services were under enormous demand in the context of the pandemic and still are. So they could have, they potentially did give relative priority to younger patients. And that might be justified on the basis of the arguments that I've outlined. Might have implications for when we think about some of these other indirect effects on children. So if we think about giving relative to priority to children, one thing that might mean is that we take very seriously the educational deficits that they have faced and think about how we can address that and alleviate that, both their current situation and also their extra needs that they might have as a consequence of missing out on normal schooling. We might think about, as we are in the UK, we're struggling to get our heads around a massive backlog of healthcare surgery appointments. We might think about giving relative priority to children. And of course, it might have implications for the topic that I said I was going to talk about, but I haven't got to talk about now, which is vaccination. So we might think that what this means is that perhaps we should give priority to children for vaccination. But is that right? Okay. So I'm going to move on to the thing that I said I was going to talk about, but I haven't so far very much, which is about whether we should be vaccinating children against COVID. So when we're thinking about this ethical question, there are three different questions that I'm going to think about that suggest that we need to think about. So one is the question that we think about all the time when we're thinking about medicines or treatments for children or vaccines. The first question is it in their best interest? And best interest is sometimes a bit confusing, but there's a simple way of thinking about it. We can think of best interests like a seesaw or a balance. Question is, do the benefits of the vaccine on this side, do they outweigh the risks of the vaccine for children? So when we think about for children, the benefits might be in terms of preventing severe acute COVID, might be in terms of preventing the multi-inflammatory post-COVID syndrome, might be in terms of preventing concerns about long COVID, and the indirect effects. We've heard some discussion already about the potential that if children are vaccinated, that might support and help them in terms of returning to education and avoiding further interruption to education. But on the other side, there are the risks. And some of those are risks that we know about. So there, of course, have been questions in relation to thrombosis, particularly with some of the vaccines, the AstraZeneca vaccine. And that's a reason why that vaccine has been not used so much in younger adults or in children. There have been, as many of you will have seen, concerns about the rates of myocarditis, particularly in adolescent males after a second dose of mRNA vaccines. So that over the last couple of months has been reported and characterized with increasing clarity. And it's clear that that is a risk that is in the balance here for children and young people. The challenge in terms of working out whether the benefits outweigh the risks is that the answer is not as clear as it is for adults. And it's not as clear for two reasons. So one is because we know that the medical complications of COVID are much rarer for children. So in the UK, data that came out just in the last couple of weeks from earlier waves of COVID showed that the risk of dying for children was about 2 in a million in the UK, and usually, in most cases, were associated with those who had significant underlying medical vulnerabilities. So those risks are much smaller than they are for adults. What that means is that it's easier for the risks to outweigh that. If there were significant serious risks, even rare, of the vaccine, you could get a situation where you would do more harm than good. And simultaneously, the challenge is that the amount of evidence that we have had, though it's changing all the time, for the vaccine in adolescents and particularly younger children is much smaller than in adults. So for good reason, the studies started off in adults. And of course, the experience of rolling out the vaccine has been, first of all, in adults. So the amount of data that we have accumulated is much greater for adults than it is for children and young people. So these double challenges mean that it's difficult to know what the right answer is. And there are different plausible views about this. Some view that the benefits outweigh the risks for children, others that it's uncertain at this point in time. So that leads us to a different possibility, which is not in relation to children's best interest, but in relation to vaccinating children for the sake of others. So many have suggested that perhaps we need to vaccinate children in order to achieve the sorts of levels of immunity in the population that would significantly curtail this epidemic. Now, the amount of the population you need to be immune to reach what's called a herd immunity threshold varies depending on the infectivity of the illness. You need to have very high rates for very infectious illnesses like measles, less for other illnesses, including like influenza. And some of the estimates early on in the pandemic were that we perhaps need 60 or 70% of the population to be immune to significantly curtail spread. Not necessarily to eliminate the virus, but to potentially reduce it. So if that's the case, then we don't necessarily need children to reach this sort of level, but there are these different answers as to what proportion of the population we would need. There's a further question about whether we can actually achieve herd immunity. So as we have all seen, the coronavirus is a changing virus, changing phenomenon, such that those who are immune to some variants may still be susceptible, at least in a reduced rate, to other variants as they emerge. So that raises a real question in the minds of many virologists about whether the idea that a certain proportion of the population being immune is going to generate what we need in terms of herd immunity. But there's an even more important ethical question of whether it's the right thing to do to vaccinate children for the sake of benefiting others. Now, when we think about adults, when we have the vaccine, when I have the vaccine, when you have the vaccine, we do it for two reasons. One is for our own health and also to protect others. And when we make a decision to have the vaccine, we of course can weigh up those competing considerations. We can say, look, I'm not worried about health for me, but I want to contribute to protecting others. Or we could make a different decision. But of course, when we're making decisions for children, particularly younger children, we're making decisions for them. It's one thing for me to make an altruistic decision. It's another thing for us to make altruistic decisions on children's behalf. It doesn't mean that we shouldn't do it, but it is a different type of ethical consideration. And particularly if the risks are uncertain, it becomes much more questionable whether that's the right thing to do. So I'm going to move on to the last part of this, which is to suggest that there's a different question which has a much easier answer. So risks and benefits for the child, difficult, different answers, maybe probably imbalance, positive, a bit more uncertain when we get to younger children. Benefiting others, ethically somewhat challenging, maybe yes, maybe no. But here's a question that I think there is no uncertainty about. And this is the other question that's related to the vaccine all along. So two questions: will it benefit me? But so could somebody else benefit more? And at this point in time, particularly when we're thinking about developed countries, it's clear that there are many places, many people who could benefit more from the scarce vaccine doses that we have available than children who are at relatively lower risk. So, and you'll all have seen, you will know that the vaccine rates, the rates of fully vaccinated in places like India, but there are countries that had even lower vaccination rates. You'll probably be aware that across Africa, the rates of vaccination is less than 2%, and even lower than that in a number of African countries. There are currently significant waves in countries with very little available vaccine, including Thailand, Vietnam, Myanmar. So the question is whether we should be vaccinating children who are at relatively low risk of medical complications when there are others who are elsewhere in the world are at much higher risk. And I think the answer to that ethical question is unlike the others, relatively clear. So I'm in what feels like a somewhat paradoxical and uncomfortable position, despite being enormously supportive of vaccines, despite acknowledging that these vaccines are very effective, despite having had the vaccine myself. despite being a pediatrician, I think it's not the right thing to be vaccinating children at this point in time. In the UK, we've recently had our vaccine committee recommend giving vaccines to adolescents, so those over the age of 12 who are themselves at higher risk, or in households where there are other people who are at high risk, but not to give it to healthy adolescents or young people. And I think for the time being, that's the right ethical balance. There are some interesting counter arguments, but in view of giving people some time to discuss, I'm going to leave those there. We might come to those in questions. And I'm going to turn back to Ravi to chair the discussion.
Thank you, Professor Dominic. Such a nice talk. There are surely no objective answers to this question, whether should we vaccinate children in the age group of 12 to 17 or not. If you see the recommendations of US ACIP versus the UK, I mean, they do vary a lot, whereas UK goes for a selective group of 12 to 17-year-olds who are vulnerable, or whose households have people who are vulnerable. Whereas USA's approach is they have adopted a uniform policy. They have reviewed the evidence for myocarditis and other things periodically, and they still feel that the risks, the benefits far outweigh the risks in this subgroup. I would like to ask Dr. Naomi to express her views on the differences between the UK and the US approach to this subgroup of teenagers.
I think I am going to relate this back. I think it depends on the justification for the difference. I think that different groups and different entities, I think, can draw different conclusions about the medicine and about the uncertainty. And that, I think, to me, is a little more about science and a little less about ethics. I think sort of where you stand on remaining equipoise, where you stand on the risks, where you stand on individual risks, I think, for one, is done by clinicians and scientists. And two, I think that is also where there's a role for parents, right? Until you're talking about compulsory vaccination for school, for example, I think there's a role for parents to make a decision about whether those are risks they want to take on or not. So I don't know that I have a strong sense of who's right in terms of what populations of the kids who are now approved for vaccine, whether it should be all of them, whether it should be a subset. I don't know that that to me is as compelling a question from a medical standpoint as it is about to the question that I posed in my slides, which is, if you are acting in a sense of global conscience, and if you're saying this doesn't make sense in a world where there are people who desperately need to be vaccinated who aren't, does vaccinating fewer healthy children in the UK get vaccine to places that don't have enough of it, and get people who really are at risk of dying from COVID tomorrow vaccinated sooner? I'm not convinced that we're capable of that kind of coordination. And I'm not convinced that it's fair to ask people to sort of not have their kids vaccinated on a principle, which I might agree with, and I actually probably do agree with, when those parents can't be assured that by foregoing vaccination for their own children, other people who need it more will be vaccinated. So that's, I think, where, so that was going to be my question for Dr. Wilkinson, actually, is how do we reconcile our sort of long history of failure to coordinate between countries and distribute resources between countries?
Thank you, Dr. Naomi. Professor Wilkinson, would you like to respond to her? How can we actually do this in practice? I mean, we are not able to allocate vaccines to countries where there is a high need for vaccination. Can we do it by neglecting children? I mean, yes, Professor Wilkinson.
So I don't think it's a question of neglecting; it's a question of prioritization. So, one of the thought experiments that I had. So imagine back in February, if I had said as a pediatrician, look, children are important. They've suffered very substantially. Their education's been threatened. Their schools are being disrupted. We need to be vaccinating children now rather than 70-year-olds. So rather than people who are medically vulnerable, we should be vaccinating children. Now, everybody in the UK would have said, you are completely crazy. That's out there. No, you can't do that. Now, we have to vaccinate those who are at highest risk first. Now, in fact, that's exactly where we are now. There are 70-year-olds. There are people who are medically vulnerable. And if we give the vaccine to our children instead of them, it's making exactly the same thing. The only difference is they are not in the UK. So now one of the interesting challenges in terms of vaccine allocation is the ethical reasons that apply at different levels. So the vaccine committees, like the JCVI in the UK or the ACIP, their remit is very small. So they really are only focused on children in the US. They don't have any capacity to think about adults in developing countries. That's not within, I don't think, within their scope of reflection. They would think, look, that question is a political question. The politicians, I'm not sure about the US, but certainly in the UK, have got zero appetite for thinking about the well-being of other countries where well-being in the UK might be in competition. So I think they take the view, everybody in the UK first, and then we'll think about people elsewhere. I think that's an ethically narrow-minded, and short-sighted view, but I think that is their view. I think they also take the view that for the sake of getting on with the economy, we'd be better off vaccinating children. It means we can forget about this virus and we can get on with other things. And I don't think they're terribly focused or worried about these ethical questions about children being vaccinated for the sake of others. So then the question is, who is going to weigh up these questions? And I think Naomi's right. It's not fair to ask individual parents to make that choice, because it isn't plausible to think that if parents are being offered a vaccine, that them saying no will enable that vaccine to go somewhere else, to somebody who's 60 with underlying lung disease in Vietnam or India or Myanmar or Africa.
Thanks, Dominic. So I would like to ask Professor Suman Rao, what's her take on the talk by Dominic? Ma'am?
Thank you, Dr. Wilkinson. It was a brilliant talk, and I enjoyed every minute of it. My thoughts on this ethical dilemma of resource allocation, and particularly working in a setting where we don't, in fact, in my medical school, resource allocation is not a day-to-day problem, but I know that it is a day-to-day problem even without the COVID pandemic in many places in India. So I feel this pandemic has sort of highlighted something which is a routine issue for many of us. And probably the West is only opening its eyes to it because they have found this issue currently. And therefore, I think we have a larger picture to look at, even beyond the pandemic, of equity and a failure to deliver where it is needed. And somehow, I think all of us are part of this big picture of failing to deliver to our babies, our children, the much needed care when they need it. So this is just sort of, I would say, has shown the tip of the iceberg that countries around the world face. And within India, for example, we have so much of inequity. We have people, like you said, who can jump the queue and get what they want. And we have people who are not even aware that there's a queue going on there and they're supposed to join it. So that's the kind of problems that we face. And as far as children is concerned, I think, yes, there is a big dilemma there for parents. But I think we are also looking at the indirect effects that we need to face now, because on one hand, we're talking about vaccines for COVID. On the other hand, we know that all of vaccine targets that we have, which are known to take care of babies, children, and survive, make them survive well, the targets are going totally haywire. So we need to act fast on that. And the other hand, the mental issues with children staying at home, that's another big picture that we need to focus on. If you ask children of my daughter's age now, do you want to get the vaccine and go to school? They'll probably say no. They're so used to being staying at home. So I think this is something that we really need to focus on. I had a question for Dr. Wilkinson about the ethics of vaccinating pregnant women, because that's the other group that we really don't have data on. And we're talking about the woman herself and her problems, and also the fetus, where we have actually no clue about the safety of this. Your take on ethical issues of vaccinating pregnant women, Dr. Wilkinson?
So it was interesting. I was talking to one of our obstetricians about this today, and he was talking about the slightly blunt way that he talks to some of the women that he sees, all of whom, when he talks to them, say, I'm worried about having the vaccine. I'm worried about the effects of my baby. Perhaps I'll wait till after my baby's delivered to have the vaccine. And his answer was to say, well, look, you're right. There's a theoretical risk if you have this vaccine of it causing a problem in your baby. There's a theoretical risk. But on the other hand, there is a very real risk that I have seen and is much, much more likely, which is of damage to your baby and to yourself from the virus. And I've looked after pregnant women early in the year in adult intensive care who were on death's door because as a consequence of COVID. So I think, unlike in children, in pregnancy, there is very severe illness associated with COVID. There are very significant pregnancy complications associated with COVID. So the risk to the fetus from if the mother gets COVID, I think it's now clear is significant and is likely to be far more than the risks from the vaccine itself. So I think if women are concerned about risks, the best way they can reduce those risks is to have a vaccine.
Thank you, Dominic. Ma'am, would you want to respond?
No, thank you. I think that was very clear.
Thank you. Dominic, Gary Weiner is here. So he's, I would love to have him on board. Gary, do you want to talk? Because you made a comment. Practically, though, you only control the resources you control. You want to comment a bit on your Gary? I think he is busy.
So he might not be able to speak.
No, I made him a host now. He should be able to speak. So what?
So he said it was covered already. I mean, I think there is an interesting question for resource allocation about at what level resources are allocated. So one of the issues that sometimes applied when we think about questions like allocation of intensive care is whether allocation should occur at the bedside, whether it should occur at a middle level in terms of above the bedside, perhaps in organization of the hospital, or at a high level in terms of the health system. And one thing that is people are sometimes drawn to is the idea that what we shouldn't do is individual clinicians shouldn't be having to make these allocation decisions. We should be making them at a policy level. I think that's an attractive answer to many resource allocation decisions. So in a sense, what that would do is to say, look, individual pediatricians shouldn't be having to decide whether to give the vaccine to an individual child or make a decision for it to be allocated to a child, to an adult in another country. If there's a policy that the vaccine is available, then they offer it to their families and they inform those families and they make good decisions. But the decision about whether it should be available, that has to be made at a higher level.
Yeah, that was clear, Dominic. Yes. Just to clarify, these whatever vaccines we are talking about are the mRNA vaccines, not the AstraZeneca or the other vaccines available back here in India. So we still don't know the associated risks with. I mean, UK, I think they are advised against AstraZeneca in younger age group, right, Dominic?
So that's right. So we are using the Pfizer vaccine and possibly Moderna as well in those who are under 40, I believe, and not using the AstraZeneca vaccine. I don't know what the evidence is on the Novavax in children and young people. I think one of the things that I didn't talk about, but Naomi mentioned, and I think it's really important, is the possibility that in our enthusiasm to vaccinate children, that we might, particularly if there are even rare complications, that we might encourage those who are skeptical about vaccines. We might generate for them lots of publicity. So if there were even a tiny number of children who got encephalitis or autism, I'm not proposing at all that that's likely or there's any evidence, but if it were the case, that would then potentially have much wider negative implications for children. So that's something that we need to think about in deciding how cautious versus how enthusiastically we embrace these vaccines in children.
Thank you, Dominic. Anything else? Does anyone want to ask any questions?
So there's a question from Dr. Weiner that I'd love to address if there's time in the comments. Would that be all right?
Yes, Naomi, yes.
So Dr. Weiner asks about whether people or families should be held responsible for their vaccine decisions in some way, and whether acceptance of a vaccine, so in the United States, now mostly we face our unvaccinated adults are generally unvaccinated by choice. That's probably not universally true, and I think that's important. But so the question is, do you have an obligation to get vaccinated, and do you have to pay the consequences if you don't? And so several years ago, well before this pandemic, my colleague Stephanie Kokora and I wrote a paper about this with regard to the flu vaccination. And we posited that if you were offered the flu vaccine and didn't take it, and then you got severe influenza, that in a time of ECMO shortage, that you would move to the bottom of the list for ECMO. Because we know that not only do cases correlate with vaccination, but severity of cases. So most of the adults who require ECMO for influenza were not vaccinated. And so this was a paper that either people hated or didn't read and sort of was forgotten and getting dusty somewhere. And all of a sudden, when the pandemic started, we noticed that it was getting cited a lot and that people were starting to talk about this again. And I think if you reframe this question in terms of COVID and children and access to public goods, saying like, what do I owe to society? I owe it to society to prevent vaccination or to not tax the healthcare system more. I think that there's an interesting theoretical argument, but you have to be careful about a number of factors. I mean, one is, I think it would be exceptionally difficult to justify limiting access to a public good by a child who wasn't vaccinated. I think that is a deeply problematic issue, because even if the parents pay for that, say, well, you didn't vaccinate your child, so now they can't go to school. I think generally it's hard to justify penalizing a child for an adult's decision on their behalf. And I think, again, then the question goes to access. So I think there's an important moral difference between was offered the vaccine and chose not to have it versus through a variety of circumstances unable to get access to the vaccine. So the minute that there is inequity in access, holding people responsible for following through on that action becomes difficult. And there are a lot of subtleties with the way that happens. So one might be you don't have a vehicle or access to a physician or the money to pay for the vaccine, but others might be you don't have the access to the information and education you would need to believe that that vaccine was safe. So I think there is some attractiveness of this kind of argument at the margins. I think that access to school being pinned to uptake of vaccination is something that we have undertaken for a long time in the United States, but based on a public health drive, not based on a punishment reward system. So we don't keep kids out of unvaccinated kids out of schools to punish their parents for not vaccinating them. We do that to have sort of micro herd immunity in schools. So I think it's an interesting idea and one that is worth talking about in a resource-rich setting in which access to the vaccine is not a problem. But the minute you're outside of that kind of context, I think that you run into significant moral dilemmas with that approach.
So, Professor Dominic, what is your view on Naomi's scenario that you are given a choice and I don't want to get vaccinated as an adult? I mean,
so it depends, I think, on the structure, on the ethical structure of your healthcare system. So one, within the context, so I've talked about this question in the context of, so a journalist asked me about this last week, and I said that I couldn't imagine that a healthcare system like the UK would contemplate making this sort of decision. And that's because the UK is very committed in its healthcare to a strongly egalitarian approach to access to healthcare. So it doesn't matter whether you got liver disease because you drank alcohol or you got liver disease because you've got a gene that caused liver problems. If you have an equal need for a liver transplant and an equal chance of recovery, then you will be considered equally. So the NHS is very committed to not thinking about people's contribution to illness in thinking about allocation of resource. And that's because it places a lot of weight on this ethical value of equality. But I could imagine some health systems, particularly insurance-based systems, thinking different. So I could imagine an insurer, for example, saying, if you get complications of COVID and have chosen not to have the COVID vaccine, that we wouldn't pay for your health care. Now that of course would then be an important factor for those who've got into health insurance and for them making decisions about vaccination. But you could think from the insurance point of view, I mean, they've got a finite amount of resources, or equally, they could say, well, look, if you're not going to have the COVID vaccine, we're going to increase your premium. Again, that would be a way of the insurer dealing with the costs associated with COVID. That's a very different ethical context to the public healthcare system in the UK.
Thank you, Dominic. Professor Suman ma'am, do you want to compare to what the medical system back here? We have a mix of everything. So we have NHS type of government-sponsored healthcare system. We have an insurance-based system, and we have purely private hospitals where patients pay out of their pocket. So if someone decides not to get themselves vaccinated, how do you think we should approach, ma'am, in our scenario? Do we make them accountable for their actions?
So as I said, the ethical issues that I think the West is facing as far as the COVID pandemic is concerned is something that we face all the time, not only with COVID vaccination, but also with routine vaccination. We have so many children coming with the diphtheria, and because they were not vaccinated, we have issues like chickenpox, they are not vaccinated. And in India particularly, I think access to vaccines, not only in terms of cost, but also in terms of, sometimes the parents, if they have to take a child for vaccination, they lose a day's job. So that's the big challenge that we face in India. And therefore, I think holding families responsible for not vaccinating their children and making this sort of benchmark or across different hospitals is not possible. Probably the only group which can do that, maybe like you suggested, is the insurance group. Because again, in India, insurance is all by choice. We don't have a national insurance which covers everyone. So for us, the ethical issue is how to get access for vaccines, not only for children now, but also we are talking about, if you look at our vaccination coverage, there is huge chunks of adults who require the vaccination who have not got it. Not only because of vaccine hesitancy, which is of course there, but also because of access. And the people who can afford it are getting it earlier. So I think we need to deal with that before we make people accountable for not being vaccinated and therefore deny them care or penalize them for it. I think that we are far, far away from that kind of approach. Over.
Thank you, ma'am, for being crystal clear on this subject. If there are no further questions from Dr. Naomi or Suman, ma'am, shall we conclude? Dominic, do you want to say anything about?
No, I'd like to thank you very much for inviting me to give this talk. It's great to be part of your webinar series, and a great pleasure to be able to talk along with Dr. Suman Rao and Dr. Naomi Loventhal.
Thanks very much for having me. It's nice to meet you all.
Yeah. Thank you, Dr. Veer. It was wonderful. And thank you, Dr. Wilkinson and Dr. Naomi.
Thank you, all three of you, for joining this webinar. This will be available in YouTube, and I'll share the link. A very important topic. We don't have those vaccines yet. And as Professor Suman Rao told, we still are yet to vaccinate people who are at risk back here in our country. So this issue has not risen as of now. Maybe once these vaccines are available in our country, the Pfizer one and the Moderna one, maybe we'll be having a debate as to whether to vaccinate children or not. Thanks, Professor Dominic Wilkinson, Dr. Naomi, and Professor Suman Rao. Thanks everyone for participating. Thank you.
Thanks. Bye.
Bye-bye.